There it goes, and I'll kick us off. So welcome everyone to this webinar sponsored by the Illinois Public Health Institute Chicago Cares. The title of this webinar is Ask the Reimbursement Expert, Get Your Questions Answered on Billing for DPP, DSMT, and Other Diabetes Care. And then we'll go to the next slide.
There we go.
There you go. And then I'll pass it over to our speaker today. And then, sorry, before we get started, I don't know if there's anyone on the line from IPHI that wants to say anything. I'm not seeing anyone, but if anytime, just send me a chat. And if you guys want to drop in anything, just let us know. But I'll pass it back over to Patty to get us started.
Well, thank you, Jasmine, very much. And welcome everyone. I believe it's morning here for me in Denver, but I believe it is, it's all lunchtime right there for Central Time. So we have about 90 minutes that we are going to actually cover quite a bit. Before I go through the agenda, I just want to give you a just high level overview of my background. I am a nurse by training. Worked PEDS ICU and ER, and then went back for an MBA, and then kind of flipped to the business side and have been with Deloitte & Touche. I was with Medtronic for about 15 years in their reimbursement. So if you have any questions on pump and CGM, I can definitely answer those. And then went back to consulting. And I have been working with Jasmine and ADCS for probably about 7 years now. Kind of doing a lot of their reimbursement webinars, as well as their frequently asked questions that come in from their members. For just disclosure, there's no conflict of interest, but I do work and do some consulting work for Senseonics and Dexcom. Jasmine, anything else that you want to say here is just as far as disclosure or anything else?
Nope, I think that covers it. Just that's why we have this slide here, just to have all the information available to you guys before we get into the presentation.
Okay, so I'm going to kind of walk through the agenda, and then we're going to just do some polling questions. And I really, really encourage everyone to ask questions and make this interactive. It will be, a lot kind of enjoyable for everyone if we can keep it interactive. So throughout my presentation, feel free to kind of put some questions in the chat box. So Jasmine, I'll kind of ask you to kind of monitor that box. If there's anything urgent as far as a question or something that I just said that might need clarification, please stop me. But then also know that at the end of kind of each section, we will have plenty of time for Q&A. Okay, so what are we going to cover over in the next 90 minutes? We're going to talk about a high level of DSMT reimbursement and some of the most frequently asked questions that come in. We are going to talk about the Medicare Diabetes Prevention Program and some changes, very positive changes that happened here in 2022. And then we're going to really talk about some remote monitoring codes. And for some of you that may just be starting to get into kind of the DSMT program, some of them you may not be familiar with, but what's important is that you use these slides kind of as a reference. And I'm really going to kind of challenge each of you to really look beyond just DSMT or just MNT. Okay, and then we're going to talk a little bit about the telehealth and under the public health emergency, and then Q&A. But again, please submit those questions in the chat box, and then we'll take them either real time or at the end of kind of each section. So Jasmine, what would be great right now is let's do just some polling questions. I think we have 2, and just really a chance to kind of get to know the group and kind of understand your reimbursement level. Okay, so what is current level of reimbursement knowledge? There is no right or wrong answer. But if everyone can kind of put in novice, intermediate, anybody that's expert, I am happy to share my presentation time as well. Okay. Yeah, so it looks like we're about half and half, that's perfect. I think the content will address those that are novice, and I think those that are intermediate will also give you some good takeaways. So I think we have one more polling question, Jasmine, before we get started. So also kind of what is your professional background? Again, just trying to understand a little bit about each of you. Okay, good. So we have a good mixture of RN and RDs. Okay, perfect. Okay, all right, let's kind of get started on the content. But before I start, does anybody have any questions or anything so far about either the format or any questions that they have that they really want to make sure gets covered today? And I think Jasmine will know pretty quickly whether we have a quiet group or an interactive group.
Absolutely.
Yeah. Okay. No questions so far, Jasmine?
Nope, I'm not seeing any in the chat box, but I'll stop you if when they come in.
That's perfect, because I don't monitor that chat box just while I'm presenting. Otherwise, I get distracted. Okay. All right. So let's get started. And we're going to kind of start with DSMT. And a lot of what we're going to cover here is specific or maybe outlines the Medicare criteria. And why that's important is Medicare is always what I call the elephant in the room. And most commercial payers in some way follow Medicare. So it's always important to really understand what is the Medicare rules, and then how do you apply those for your commercial payers. First of all, in order to bill for DSMT, you'll also see the acronym DSMES. We're talking about the same. From a reimbursement in Medicare terms, it's usually more DSMT. From accreditation, you'll kind of see it as DSMES. So one, you have to be a Medicare provider. And another rule, or I kind of call it a caveat, is you do need to be billing for other reimbursable services. So let's walk through what that means. If you are a physician, we don't have any physicians per our polling question, but let's just say if you're a physician, you're billing for other services than DSMT. If you're a hospital, you're billing for services other than DSMT. Let's take those that are RDs. If you have an accredited program as an RD, that's great. You can be the sponsor of a program, but you would also then need to offer MNT. So you are, coming back to my first bullet point, billing Medicare for other reimbursable services. Second bullet point, you must have an accredited program either by ADCES or by ADA. Once you have that accreditation, the QC is a quality coordinator. You must send that information to your MAC, which is your Medicare Administrative Contractor. They need to have your certificate of accreditation on file to know that you have a program and therefore claims can go through. Just some background information, accreditation is for 4 years. Working with ADCES, we really recommend that you kind of look at your timeline and make sure that you submit kind of that renewal application at least 30 days prior to the end of the accreditation. Okay, so takeaways here. Must be billing for services other than just DSMT, and you must have an accredited program, and you must submit that accreditation to your Medicare Administrative Contractor. From a private payer perspective, many also require accreditation, but that will vary. So as you look at the payers in your local market, you will want to reach out to them and really understand their specific coverage criteria, but also do they require accreditation? But even if they don't require accreditation, I really strongly encourage all of you to consider getting an accredited program. And the reason why is it can help you possibly get into what they call in-network. And many payers, especially Blue Cross Blue Shield, you have HCSC in Illinois, and sometimes they say that they are a closed network and it can be hard to become a new provider. So having that accreditation can many times kind of put you kind of at the top of the list and really help move those negotiations to get in network. Private payers have different coverage. Some most likely it's more broad than CMS, but again, every payer is different. And again, from a payment level, typically commercial payers typically pay around 120% of Medicare. Okay, so kind of first things first, how does the Medicare coverage work for DSMT? First of all, you will need to get a referral. And that referral, again, you'll have access to these slides. So if you kind of forget, come back to the slides. So that referral must come from a physician, or it can come from a qualified non-physician provider. That would be your nurse practitioner, your PA, or possibly your CNS. However, if you look at my 2 bullet points there, that physician or qualified non-physician provider must be treating the beneficiary's diabetes. So what does that mean? Or when do we see this come up? One might be if the referral is coming from a podiatrist. That podiatrist, may be seeing the patient frequently, especially if they are having foot issues, but they're most likely not treating the beneficiary's diabetes. Another time I see that is with the hospitalist. So say the patient is newly diagnosed and they have been in the hospital and they're being discharged. If that hospitalization is related to a diagnosis of diabetes, they obviously need diabetes education, but that hospitalist is not per se going to be treating the beneficiary's diabetes. That patient will need to get set up with a physician or provider to treat their diabetes. That would be ideal, and then have that referral come from them. But if for some reason that patient cannot get with a physician or a provider, I think if you document referral came from hospitalist, need to get patients started as soon as possible, you could certainly probably start the process of providing them diabetes education. So to qualify under Medicare's definition of diabetes, and what I mean by that is they do need to meet this definition in order to qualify for the DSMT benefit. I'm going to start with A1C is not on this list. It can seem crazy. For example, you have a patient come in with an A1C of 9. Doesn't take much clinical background to know that that patient probably has diabetes. But Medicare does not yet recognize just A1C. So they need to have one of the 3 blood tests that are listed here, either a fasting blood sugar, 2-hour post-glucose challenge, per the limits, and you will see that those are on 2 different occasions. I get a lot of questions. Can we do them on the same day? Do them back to back? My answer there is always no. It says 2 different occasions. The random glucose test, Medicare does state as 1 occasion with those showing symptoms, and an A1C could certainly be a symptom there. Another question I get is who needs to keep these lab results in their chart? The referring provider must have these in the chart, but I do encourage each of you to also have them in the chart. And the reason why I recommend that is you are billing Medicare for services that you are assuming that that patient is qualified to receive. So if there is an audit, and by chance this patient never had any of these tests, the physician just referred them on A1C, that could put you in a situation that they may be auditing and saying, are those claims valid? So again, just ask the referring provider for those lab works, or if you're part of a system, it may already be in the electronic health record. DSMT is paid under the physician fee schedule. Okay, so even if you are a community facility, if you are a hospital, it is always paid under the physician fee schedule. Now I say that unless you are kind of a federally qualified health center or a rural health center that has their own payment methodology. Okay, but for the most part, if they are fee for service, that DSMT would be paid under the physician fee schedule. Here's a question, an important point, since we have a lot of RNs, and some of you may be RNs and also an RD, but if you are an RN with or without a CDE certification, you can and always should be part of the DSMT accredited team. However, the billing would be done under the MPI, which is the billing number of the accredited program. And that billing MPI should be the sponsor of the accredited program. So what do I mean by this? So an RN, again, whether CDE or not, can get an MPI, but Medicare does not recognize RNs as providers that can bill under their own MPI. So that RN, their services, they can provide DSMT, but the billing would be under the program. So whether that RN might work with an RD, they might be employed by a community center, they might be employed by a hospital. Again, I get that question so often, or they'll say, my finance team tells me I can't bill for my nurse. Yes, you can. It just needs to be under the sponsor of the accredited program. Here is the payment rate. So for DSMT, the two codes are G0108 and G0109. G0108 is one-on-one. G0109 is group. Kind of how I remember that, 9 is higher than 8, which says that there's more people. Each of these are 30 minutes. And if you are providing group training, you need to make sure that you are billing for each patient in that group. For MNT, there are 3 codes, 97802 and 97803 are one-on-one. 02 is for kind of the initial training, and then 03 is for follow-up, and then 04 is for group training. We're not going to spend much time today on MNT, but I really do encourage you, as you either are doing DSMT or starting a program, that you really look to also offer MNT. MNT does require an RD to be part of that staff. But when we talk a little bit high level about your financial value proposition, every patient most likely could clinically benefit from both DSMT and MNT. And the math is pretty straightforward. You can almost double your revenue per patient by offering both, as well, and most importantly, better serving them clinically. DSMT is a separate Medicare benefit. It is not considered incident 2. So again, I get asked a lot, well, what if I don't want to go through the accreditation process? Can I just bill the lowest level 99211, which is basically a nursing visit, for DSMT? That answer is really no. It is not intended to be incident 2. It is clearly part of the Medicare DSMT benefit. And I will always add my kind of financial or reimbursement points. You don't want to bill a 99211 for DSMT from a reimbursement perspective. 99211 pays around $15. It is not time-based. So whether it's 30 minutes or whether it's 2 hours, that 99211 would only pay $15. If we go back to our slide, you'll see here, if you're doing an hour of one-on-one, because it's, I'm saying 2 units for GO108, 30-minute unit, you're doing it for an hour, you are getting around $110 versus the 99211. You're gonna hear me kind of repeat this kind of throughout my presentation, but probably the biggest question I get is under the MPI, and if they get denied, how do I bill for the RN's time? RN's part of the accredited program, but the billing is never done under the RN. It is also never done under the pharmacist. If there's a pharmacist as part of the team, either the hospital or the physician or the RD would be the sponsor, or the pharmacy. You can bill under pharmacy, just not the pharmacist. Any questions or anything, Jasmine, that you would add so far? I just want to kind of make sure, you know, go on, give everybody a chance to kind of take a break and ask questions.
I don't have anything to add, and it looks like we don't have any questions yet pertaining to what you've covered yet. Okay,
awesome. All right, we talked about the referral, which is required. It must be signed by, we said the MD, it can be a DO, or it could be a PA, nurse practitioner, or a CNS. ADCS has great resources for their members. So they also have a template, and I say template because it really needs to be patient specific. On that referral, it does need to say the number of hours. It needs to say the topics to be covered. They need to specify whether it is for group or one-on-one. And I strongly recommend that you always maintain a record of that referral in the chart. So to the right here, we just have kind of a sample. This was even been updated for 2022. And a lot of times you'll hear from physicians that they just don't have time to make the referrals. So really make sure that they know that there are tools out there. You can provide this template to your referring providers, and it does make it pretty straightforward. But you, as the team providing the education, should never fill out that form and then just ask for a signature. It does need to be filled out by the referring provider. You will also need a separate referral for MNT if you are also, if that patient also needs MNT. So let's get into a little more kind of detail of the DSMT benefit. Medicare and many of the commercial payers breaks it down into what they call initial training and then follow-up. So that initial training is 10 hours. 9 is expected to be group. 1 can be one-on-one. I have a slide about 2 down that will talk about what if this patient needs more than 1 hour of one-on-one. There are options there. This is a once under Medicare program, one-time benefit. Then the patient has every year, they are eligible for 2 hours of additional DSMT. You do need a new referral, and all of the follow-up can be either one-on-one or group. Federally qualified health centers, that's a little unique. If anybody is from a federally qualified health center, feel free to ask more questions, but you would bill under your prospective encounter rate, and those would need to be provided one-on-one. That's just how it works within federally qualified health centers. So for the initial DSMT, you heard me say that it's for 10 hours. It's a one-time benefit. So how do you know if that patient has actually used that benefit? If you look at kind of my last kind of bullet points there, you can call your MAC, and technically they should be able to tell you whether the Benny, that means the beneficiary, has used that benefit. And I always get a little cynical because if they have used it and you are billing for the 10 hours, you will get denied. But yet sometimes your MAC may say they don't have that information. So here's kind of a little trick. So if you do not know if this patient has used their 10 hours of initial DSMT, I encourage you, and you can write this down as a note, to bill 2.5 or 3 hours. Some of you might say, where did I pull that number out? Well, remember, they are eligible for 2 hours every year. So the first 2 hours are going to go through. So when you bill that 2.5 or that third hour, that's going to differentiate between initial and follow-up. I would recommend that you also get an ABN, Advanced Beneficiary Notice, when it's a new patient, just to make sure if that patient has already used those hours. Without an ABN, you may be responsible for that. The groups, as you see here, can be really any size, and they do not need to be all Medicare beneficiaries. I get asked that a lot. Can it only be grouped with other Medicare patients? Absolutely not. You can have commercial, Medicaid, and Medicare all together.
Hi, Patty. We do have one question.
Oh, perfect.
So we have a question here. For FQHCs, you bill under one-on-one visits, but do the visits need to be group or can they be one-on-one?
So in the case of a federally qualified health center, they need to be one-on-one because it is actually considered a medical visit. So your DSMT would be provided one-on-one and paid under their encounter rate. And for the participant that asked that, does that answer the question? Feel free to just speak up or say, I need further clarification.
Yes, thank you. So can that visit, one-on-one is what I was hoping to hear, and that can be done by a dietitian?
Correct. It can.
Perfect. Thank you.
Yep. Awesome. Thank you for asking questions. This is really your chance. If you have questions or if Jasmine and I don't know the answer today, we can get back to you. So I really, again, just encourage you. There are no questions off limits. This is really your opportunity to have both of us online and ask any questions. Okay, initial DSMT. This gets a little complicated. So for those of you that are new, you may need to come back or underline some of this in the slides. The 10 hours must be furnished within a 12-month continuous period. That 12 months starts on the date of that first visit, not on the referral. They can be provided, those 10 hours, in any combination of 1/2 hour increments over the 12-month period. There is no rounding up, and the DSMT must be, I say face-to-face, if it's provided via telehealth, and lots of exceptions under the public health emergency, but to allow for flexibility as far as face-to-face in person, but those 30 minutes must be spent with the patient. It is not including time charting or checking the patient in, for example. That 10 hours is initial, that is the maximum. You talked about the ABN, either the patient or the provider will be responsible for charges if it exceeds that and they are denied. If you have a patient that needs more than the 1 hour out of the 10, again, 1 hour, Medicare expects to be one-on-one, 9 as group, there are some certain conditions. One, the referring physician must include on the referral that the beneficiary has special needs that would hinder group participation. That might be vision, hearing, language, non-ambulatory. Another reason is they do say no group session available within 2 months of referral date. I do hear people immediately say, well, what if we just don't offer group? Can we do all one-on-one? Unless you're a federally qualified health center, that answer I would say is no. That's not the intent of it. But again, Medicare is trying to say, all right, so there really could be a case that you don't have a group session within 2 months and they don't want that patient waiting. And then also if there's additional insulin training, I will add here that if you are providing more than that 1 hour of one-on-one, do be prepared most likely to have to file an appeal if it's denied, because Medicare may need to understand why are they getting additional one-on-one. So just be prepared. The follow-up training. So that is every year, and that is 2 hours. This is furnished by calendar year. And I do have some examples that I think will help it kind of bring it all together. These 2 hours can be individual or group, doesn't matter. This patient can have the 2 hours even if they've never received the initial training. But once you start the initial training, so you've used, say, 4 of those hours, they lose them if they don't use that within the 12-month continuous period. Now for follow-up, they can get that every year, and they're eligible, regardless if they've already had the initial training. All right, so let's give some examples here. Let's do 2. 1, you completed the 10 hours spanning 2 years. So let's say you started in August of 2021. You heard that must be completed 12 continuous months. So that gets you to August of 2022. They are eligible then for the 2-hour follow-up starting in September because it's a new calendar year. Follow-up is calendar year. They must use those 2 hours by December 2022. Eligible for the next 2-hour follow-up in January 2023. I will make a statement here that taking 12 months to provide the 10 hours would not be my recommendation. And the reason why is you could have a higher instance of that patient either dropping out or losing interest. 12 months is a long time for those 10 hours. So let's take our second example. And let's say they do it the same calendar year. They start in August 2021, just like the other example. However, they complete those by December 2021. Again, that's a much more concise time period, less chance of losing patients. I will tell you, losing patients is bad clinically for that patient, but it also means lost revenue for each of you. They finished December 2021, eligible for the next calendar year, starting in January. They complete that 2-hour by July. Once again, eligible for 2 hours in January 2023. So for those of you that are new, I really recommend that you take the slide, look at it, build into your encounter forms into your encounter forms, and make sure you have these timelines. And for those, the follow-up visits, make sure you have a process around November or December to be reaching out to your referral base and say, Dr. Smith, just want to make sure you know that patient XYZ is eligible again for 2 hours of DSMT and hopefully 2 hours of MNT. Okay. The DSMT.
And Patty, oh, sorry to interrupt. We do have a question in regards to the last slide. So it says, so the first 10 hours has a total of 12 months to complete, but the 2 hours annually is based on the end of year and not the date of their first visit.
Correct. 2 hours is calendar year. The initial 10 hours is 12-month continuous.
Right. Thank you, Patty.
Yep. So these are time-based. They are 30 minutes. So if you provide 2 hours, you need to bill for 4 units. I can't tell you the number of times we'll get a call and they'll say, you know, Medicare or commercial payers didn't pay. Correct. I only got paid $58 for one-on-one. And I ask, well, how many units did you bill? And they said 1. And I'm like, well, then you got paid correctly. So make sure you have the number of units correct. And again, somehow on your encounter form or as you submitting these claims, make sure there's kind of a double check that it's being billed under the correct number of units. As far as a virtual DSMES or DSMT program, right now, Medicare does not cover 100% virtual programs for DSMT. ADCS does accreditate virtual programs. Some commercial payers, and especially some self-insured, provide coverage for the virtual, but just know for Medicare, they do not. Now, DSMT and MNT are on the telehealth list. And under the public health emergency, we're going to cover this at the end, Medicare's provided tremendous flexibility. But just overall, if you are a 100% virtual program, you're kind of unique as it stands for Medicare coverage. All right, we have a couple slides on potential denials. These are important. And I also strongly recommend that each of you gets to know your billing office. So on a quarterly basis, you really should say, can I get a copy? Can I get a report of what was billed and what was paid? Because if for some reason a payer's not paying or billing is being done incorrect, unless you start to track that, you're not going to know. And a lot of people like to just say, keep their head in the sand and say, hey, I'm sure someone will let me know if there's a problem. I really encourage you to be more proactive and really make sure you understand, am I getting denied? And if so, let's change what we're doing. So a couple potential reasons. One could be referral not from the physician treating the patient's diabetes. I will tell you that's probably the least of the reasons I see a denial. And that's because the only way that Medicare is going to really know that is if they do an audit. But again, I want to make sure you know that that's kind of the rules are the physician treating the patient's diabetes. Or we see this a lot. The MAC does not know that you have an accredited program. And if you have off-site locations, you need to make sure that your MAC, Medicare Administrative Contractor, is aware of that as well. Denial of the initial 10 hours. What could cause that? One, patients already used their 10 hours, more than 1 hour of the one-on-one, not furnished within the 12-month continuous period. So again, you kind of need to, one, know that it was denied, and then two, understand what may be causing that. As far as the follow-up, may not have adhered to the calendar timeframe. Again, can be one-on-one or group, so that should not kick out a denial. But about 18 months ago, we did have a contractor in the Northeast that for some reason was kind of asking for additional documentation when it was one-on-one. But that has been fixed. I have not seen anything from the Illinois MAC as far as problems here. So here, it's a legitimate claim, and you're doing more than one of the one-on-one visits. So make sure that you have the documentation. Make sure it's on the referral to make sure that they understand that, hey, we did do more than the one-on-one. Again, this is within the 10 hours of initial, and here's why. Do not be afraid to appeal. I always say Medicare and most of the payers, I think, try to make life somewhat difficult because they hope people won't appeal. So please, please, please understand if you're getting denied, then understand why, and then change or appeal if it was billed correctly and denied for some reason. Other reasons, and I do see this a lot, the RN or the pharmacist was used as the rendering provider. RNs and pharmacists can furnish DSMT, but they are not recognized as a Medicare provider. So they cannot bill Medicare directly. It will be done, and I'm repeating myself, the MPI of the sponsor of the accredited program. Another reason for denial is DSMT and MNT are provided on the same day. Patients are eligible for both services, just not on the same day. And for some reason, Medicare doesn't like individual and group furnished on the same day. I don't see that happen, because typically from a scheduling perspective, it's either or, but just know that can kick out a denial. Okay, so after you kind of get a handle on your billing, another takeaway I want you to have is really understand your value proposition. So we're going to talk about diabetes prevention program. We're going to talk about remote monitoring, which can add additional revenue opportunities. But even let's kind of just stick with DSMT. And you may, or you may already have had a conversation with your finance department. Maybe you went to them and said, I need more staff. Or they came to you and said, you are in the red, we have a problem. So here's some points. And in a longer webinar, we kind of go into more details here, but today I just want you to kind of have some talking points. One, revenue is one metric. So hopefully you're in the black, but it is one revenue. Your education program can increase engagement with the larger organization. It may increase referrals. Also realize and understand how your program may be helping the physician or your hospital achieve pay for performance metrics. And that is huge. I will say every, and it's really hard to use absolutes in reimbursement, but every pay for performance includes some kind of diabetes metrics. And in the past, they were all kind of the carrot. So if you wanted to participate, you could get a bonus. That's not the case anymore. For Medicare and for most commercials, it is now the stick approach. And if you don't meet these metrics, it's a 2%, in the case of a hospital, 2% across the board payment reduction. Talk about ER encounters. If you're able to get patients under better control, you may be able to lessen some of those unscheduled or uninsured ER encounters.
Patty,
Yes.
we have another question. And this is relating back to earlier slides, but if a hospital is the sponsoring program, it should be under their NPI number and not a provider from the center. We are a hospital-based outpatient clinic accredited program.
Okay, so if I heard that correctly, it is a hospital-based program. I'm just going to say St. Joe's, for example. So when they got accredited, I am assuming that it is St. Joe's that was the sponsor of that program. And yes, that MPI would then be under St. Joe's. Now, I heard the word clinic, and sometimes a clinic can be in a hospital, but it might be a physician's office. So you could have a program that maybe is sponsored by the physician. My response there is make sure and go back and look at who was the sponsor of your program. And that would be the MPI that it needs to be billed under. Did that answer the question to the participant?
Lisa, if you have any other questions or any follow-up on that. Oh, she said, thank you. Not a physician's office, but a clinic took the space in the hospial. Answered.
Yeah, that's perfect.
So thank you, Patty.
Yep. All right. And again, we only have the 90 minutes, so we can't go into all of the different, we call them other billable services. We are going to cover remote monitoring, but We talked about DSMT. We talked about MNT, medication therapy management. That's MTM for pharmacists. Continuous glucose monitoring, chronic care management, remote patient management. And then the LMLP is just just letters put together. Point here is really just make sure that you're looking beyond just DSMT or MNT. It really can expand your revenue opportunity. And most importantly, it also improves and expands what you offer to your patients.
And Patty, we have one
Maybe-
more question. Sorry, don't mean to interrupt.
No, but let me just finish one statement, then I'll take the question. And don't be afraid to offer some services that may be cash pay. So you may see some weight loss programs or things like that that may not be covered under insurance. More and more patients have high deductible plans. So they're paying the first $2,500, possibly more out of pocket. So just know that they may choose to pay for weight loss programs or other kind of things that are not typically covered by insurance. Okay, sure, let's take the question, Jasmine.
Okay, and then we have a question. Will the billing change if there are multi-sites off that hospital-based program?
So good question. So if it's a multi-site, if it's all, and Jasmine, you tell me if I'm wrong, I'm going to answer it from an accreditation and then from a billing. The short answer for billing is if they are all part of the same hospital system, there is no change in billing. And then my next statement to that is if, are any of them considered off-site? And if they are all part of the hospital system, correct, Jasmine, then they're all part of the original accreditation. Is that correct?
Yeah, if
Yeah.
they're hospital owned.
Yeah.
But I believe for multi-sites, I believe that's referring to ADA accreditation. So I would just always refer back to your accrediting body for your DSMT, DSMS program on what could be an approved multi-site or what we call them branch sites.
Okay, so we're going to take about 10 minutes and then talk about the diabetes prevention program. And if I can just get even a show of hands, and then Jasmine, I'm just going to ask you to kind of tell me those results. How many of you are offering diabetes prevention?
And you guys can see the raise hand function at the bottom. It's underneath reactions.
And if you are, raise your hand. Okay, 3. Perfect. 4. Okay. So for those of you that are not, another takeaway from today is I want you to consider becoming part of the diabetes prevention. I say program, I say plan. And the reason why is Medicare covers diabetes prevention and most commercial payers cover diabetes prevention. I'm going to walk you through the coding and all of that, but why is that important? Because many of these patients are coming into the system earlier. Before, you may not have seen them until they had a diagnosis of diabetes. Now they're coming in when they are diagnosed as high risk or pre-diabetes. And if you're not offering diabetes prevention or the pre-diabetes program, you may be losing patients because once those patients start at a DPP program, and some of them will go on to develop diabetes, they may very well stay at that program for then their DSMT, their MNT, and all those other services that we talked about. So again, becoming part of the diabetes prevention program can get patients possibly into use sooner. And you can keep them. All right, first of all, diabetes prevention program is different than DSMT in the sense that it is considered a preventive service. So there are no Medicare copays for DPP. Diabetes diagnosis exclusion only applies at the time that they start. So you may have a patient that came in under the diabetes prevention program and they may go on to develop diabetes. That patient is then eligible to stay in the diabetes prevention program and also with referral and everything that you just learned about DSMT, be eligible for DSMT. And I'm a nurse, so I always come back to clinical, but from a reimbursement, I always want to point out the financial benefits. So you saw there, that patient may be giving you 2 revenue streams. High level Medicare coverage criteria for the MDPP, which is the Medicare Diabetes Prevention Program. And this is a whole separate benefit under the Medicare program. Patient must be enrolled in Part B. They do have to have a BMI. You'll read here 25 if not self-identified as Asian, or at least 23 if identified as Asian. Here, they do accept the A1C. Okay, and they give you the levels here. No previous diagnosis of type 1 or type 2. If they had gestational, that does not exclude them. They cannot have end-stage renal disease, because if a patient has end-stage renal disease, they've kicked in a whole separate Medicare benefit, and they're no longer under kind of the standard Part B program. The payment here is very different. It is not per se fee for service. So under DSMT, you saw it's time-based. Patient comes in for an hour of DSMT, you bill 2 units, you get paid 60 minutes, and you're really not based on whether that patient gets better, and you're not really going to be penalized if they don't come back, other than you don't get the revenue. But under DPP, it is a performance-based payment structure. We're not going to go into all the details. This could be a whole webinar in and of itself. But know that payment is directly tied to attendance and or weight loss. There's a whole set of new G codes, about 15 of them, that you use when billing for Medicare diabetes prevention. You do need to be part of the CDC program, all of that, to become eligible to bill Medicare. Medicare also does not currently cover the virtual DPP programs. There's still discussion on that. There's some opportunity. If a patient missed a session, you can provide that virtual. Again, flexibility under the public health emergency. But if you are only a virtual program, right now that is not covered under this coverage DPP program. So here is, so the 0403T, that is more for the commercial payers. I have another slide in a couple that will walk you through the G codes, but I do want you to know that many of the commercial payers are also paying for DPP. So even if you're not necessarily part of the CDC, you're not at that level, know that some of the commercial and especially some of the self-insured will pay for that. So if you're looking at your private insurance, look at your state health departments, look at your self-insured. All of that could be opportunities for you to go in and start a diabetes prevention program. You will need to negotiate with those payers, so let them know that Medicare covers it. Most commercial payers are also covering prediabetes. Most of them under that 0403T code. And payment, I'm going to walk you through here in a slide how Medicare pays. It is complicated. I would recommend for your commercial that maybe you negotiate a different payment methodology. However, some, even with your commercials, are asking for some pay for performance. And that will make a little more sense here in 2 slides. Okay, so kind of coming back to some of the changes for 2022, and that's where I'm going to walk you through the G codes. First of all, as of January 1st, Medicare is waiving the provider enrollment fee. That used to be $599. Medicare is waiving that. They really are trying to get more providers to participate and offer the diabetes prevention program. Again, we're not covering it in all detail, but the DPP service period used to be 2 years. It's now down to 1 year. And that is really important because removing months 13 to 24 decreases the risk of losing those patients. Again, providers are at risk. They have to have patients complete the program to get their maximum payment. So as a result of eliminating that second year, Medicare did a complete redistribution of payments. So they moved more of the payments to be, obviously, to be completed within 12 months versus 24. The total available payment right now, assuming that all metrics are met, is around $705 per patient. So again, kind of looking at this from a financial perspective, really encourage each of you to say, does this make sense? This is a once per lifetime benefit. So once a patient starts in the diabetes prevention program for Medicare, they must complete it or they lose that benefit. They can't start for 6 months, quit, and then think they're going to start again the next calendar year. Again, some slight flexibility under the public health emergency, but for the most part, it's a once per lifetime benefit. All right, so here is high level where they landed with the 2022 payment rates. But rather than the payment amounts, I want to make sure you understand how it works. You heard me say pay for performance. So here, core sessions. They get paid, you as a provider gets paid for the first one, then they don't get paid again until the 4th session. Then they get paid for the 9th. You'll see here under the core maintenance, if that patient has the weight loss, that payment is significantly increased. $15 to $75. They also must attend. So say patient drops off after the 5th session, they don't get paid for any of these. Okay, so kind of takeaways here is really one, each of you should really look at can and should you get involved in offering diabetes prevention. Be aware of how the payment works. For those of you that have already started to offer diabetes prevention, as that payment rate went up, I really encourage you to go back and make sure that each of you are looking at your charges. Medicare will pay charges or fee schedules. So if your charges are less than the new fee schedule, you're going to get paid your charges. So again, looking at your fee schedules to make sure that you understand and that you have charges above your Medicare fee schedule. And then really a lot of times people are saying patients just can't make a 2-year commitment. It has now changed to 1 year. So have that discussion with your patients. Right now, there's no enrollment fee, the redistribution of payments, all of that was very, very favorable. CMS really is trying to get patients more engaged. They are starting to realize the benefit of preventing complications. I used to say, you know, Medicare fights over DSMT education, yet they'll pay without any hesitation an amputation. They're really, really starting to try to be more proactive. From a Medicaid coverage, just high level for Illinois. Yeah, so actually I think here, so Medicaid is covered. And I think for some reason, oh, Jasmine, this one didn't get updated. So it's not under the state legislative, but they do cover it. And we can, for anybody that has any questions on that, we can add that. Right, Jasmine, first we updated that. We had, there is
Yep, that
coverage on-
must have gotten mixed up in the updates of the slides, but yes, it
Yeah.
Medicaid is covering, and IPHI is actually offering a lot of assistance, as you guys probably know, if you guys are interested in that.
Absolutely. Okay. Any questions, comments so far?
We do have a question from Kay, and maybe they might want to reframe this because I might have missed where I saw this. But they stated, what about chronic kidney disease? And I don't know if the question is in regards to coverage. So Kay, if you want to add some more information on that, or just unmute yourself to kind of give us some more.
Hi, yes. So back when you were talking about qualifying for the DPP program, you had said that they cannot have end-stage renal disease. And I was wondering about chronic kidney disease, because I've had several clients interested, but they had chronic kidney disease.
So absolutely, Kay. So chronic kidney disease would not disqualify them. It would really only disqualify them if they actually are considered end-stage renal disease. So most of them means that they're already on dialysis.
Okay.
And they have given, to be end-stage renal disease, they have actually given up their Medicare benefit and moved on to end-stage renal disease Medicare benefit. But just chronic kidney disease does not preclude them.
And could I ask one more quick question?
Yes,
I'm sorry, because I realized Lisa posted hers as well. But about the once per lifetime benefit, what about patients who were in a pilot program? Because my office had a grant for Meridian specifically, and the clients were in the pilot program. Does that exclude them from going through another formal DPP?
So very good question. So do you know if there was billing done to Medicare? Because many times under the pilot program, while they're trying to get the CDC, they actually were not billing.
I don't know if the billing actually went through. I know I had to fill out the paperwork, you know, use the G codes and all of that, but I'm part of a medical school. And so I don't know where it went after it left me.
So I would ask, I don't know if it was Kay or Lisa, if Medicare was actually billed. My guess is it probably was not. They had you submitting the G codes for tracking purposes. But if by chance Medicare was billed, Medicare did pay, then that would be considered they've used their benefit. But for most of the situations that you described, I found they were not billing Medicare under the grants and under the pilot. Does that make sense?
And Kay said, thank you.
Okay.
And then we have one more question from Lisa. And it says, in our organization/hospital, another department has a DPP program. This department works within the community and has community programs. They are not within our ADA accredited program. How can we merge these two together so that they can bill?
Well, the accreditation, whether it's ADA or ADCS, is very different than the DPP. You don't have to be per se. Yes, let me answer this without getting too confusing. So if you are part of the same health system and you have an accredited program billing DSMT, I mean, there certainly would be a possibility to try to coordinate efforts for the clinic or the program offering DPP. Again, many times different patients, different codes, different criteria to bill. Like there's a lot, like to be a MDPP provider, you have to apply to Medicare specifically as a DPP provider. You need to meet their criteria, etc. So to answer that, you certainly can, but just make sure that those are two very different services. Okay, so I'm going to move kind of quickly here, and I will leave at least 10 minutes, Jasmine, for the questions at the end, especially with a lot of new participants. I'm going to kind of go high level here on the remote monitoring, but takeaways, always keep trying to drive the takeaways. take these slides, really kind of come back with your team and say, all right, what other services under some of these new remote monitoring codes can and should we be offering? All right, so remote monitoring, this is a whole shift in healthcare. And if there is one good thing about COVID, I think it was how fast it moved healthcare to away from non-face-to-face to telehealth and virtual care. What happened in 18 months due to COVID would have taken probably a decade without it. So both Medicare and commercial payers have moved significantly in their willingness to cover non-face-to-face services. Really, 4 years ago, Medicare did not offer any payment if it wasn't done face-to-face. All right, so those of you that are familiar maybe with telehealth, prior to public health emergency, lots of restrictions. Patients had to live in a rural community. Physician shortage area was kind of the qualifier. Patients could not get telehealth services in their home, so they had to go to an approved facility. When we're talking about remote patient monitoring here, these codes do not have any of those restrictions. Okay, patients can be in their home for remote patient monitoring. They don't need to live in any rural area. When we talk about remote monitoring, you're going to see there's a lot of different codes. Strongly encourage really good documentation. You're going to see, and I'm going to walk you through, these are time-based codes. They're very specific on who can provide that care. Document. Some of the activities that can be billed under these codes is if you are using remote monitoring tools, if you are counseling and educating the patient. Many of these codes can also be billed for time spent with the patient's caregivers. That's new. Under DSMT, that care must be provided directly to the patient. Can't be, to the caregiver. Caregiver can be part of it, but the patient must be present. Here, there are opportunities if you are billing or for you're providing communication, coordination with caregivers. When billing remote monitoring, you do need to have consent. And you need to either get that verbally, but you need to write it in the chart that the patient has provided consent. In the past, they used to require a consent for kind of each of the codes that we're going to cover. Right now, they can get providers can get a single consent. And it's important because patients are going to get a copay. So they may say, I never even saw a physician this month. Why am I getting a copay? Why am I getting a bill? So that needs to be explained when you get the consent. So there was a lot of changes under the public health emergency. That's kind of the PHE. We don't really know how much Medicare and the commercials are going to stay with that flexibility after the public health emergency, which just saw yesterday that is going to be extended at least probably through August. But after the public health emergency, there must be an established patient relationship if you're billing any of these remote monitoring. Okay. Last bullet point, any devices that are used under these must meet the FDA definition of a medical device, and that data must be electronically collected and transmitted rather than self-reported. And as I move into these slides, that's going to make a little more sense. One of the remote monitoring codes that I really want you to at least be aware of is 99091. And as we walk through these codes, I really want you to look at the descriptors, because that descriptor is going to answer 3 questions. What needs to be done in order to bill? Who needs to provide the service? And how much time? All right, so this code, what is it? Collection and interpretation of physiologic data, digitally stored and transmitted by the patient. Okay, so it tells you what needs to be done. to the physician or other qualified healthcare professional that says that this time must be time spent by the physician or qualified healthcare professional. I will point out when RN and RD staff time counts, this is not one of them. Physician or other qualified healthcare professional, 30 minutes. That fee schedule is $54.75. Some more detail on this. You must have consent. Again, out of that $54, they're going to have a 20% copay unless they have a secondary. You can bill 99091 no more than once in a 30-day period. The code does include time spent assessing the data, reviewing and interpreting. It can include communication with the patient and or caregiver. But again, 99091, that 30 minutes of time is for physician, nurse practitioner, PA, or CNS. This code 99091 could be used for digital transfer insulin pump or glucose data. We are not covering today's CGM. There are specific codes for continuous glucose monitoring. So if you're getting data from a CGM device, you would bill the 95251 because that's a specific non-face-to-face code for CGM. But if you are having a patient somehow use another system, not CGM, and digitally transmitting those to you, this code may be an option. Also for possibly, there is a ton of new digital apps that are out there. And just be aware, you saw on my slide that they must be FDA approved as a device. But again, lots going on in the space. Be aware that there are opportunities for billing for non-face-to-face time. So the codes that we're going to spend time on here is 99457 and 458. Okay. So most of these codes must be provided by a practitioner, and that means physician or nurse practitioner PA, unless the code description specifies clinical staff. Chronic care management codes. Again, we don't have time to go into all of those details. Chronic care management are time-based, and they do allow the time spent by clinical staff to count towards the 20, some of them are 30 minutes of time. We're going to cover 99457 and 48. Again, these are codes that clinical staff time does count. Clarifying again, qualified healthcare professional, PA, nurse practitioner, CNS does not include RDs, RNs, or pharmacists. Okay, so let's cover these two codes, 99457 and 458. Make a note of them if you are not currently offering them. Let's go through my list of three: who, what, and how long. 99457, what? Remote physiological monitoring, treatment management services. Who? Clinical staff, physician, other qualified healthcare professional. How long? 20 minutes. Most of these codes are all billed once a month. Then the 99458 is the additional 20 minutes. So if there is by chance 40 minutes, again, it can be accumulative. So the clinical staff may have 15 minutes, physician may have 30 minutes. You can combine those to reach the 20, or in this case, if you're billing both, the 40 minutes. Kind of in the same family of codes of the 99457. Again, that is really just you looking at data, talking to the patient or caregiver. There are now codes if you are actually setting patients up on remote tools. So 99453, again, there may be some digital apps that you're setting patients up on. You can bill for that. 99454, if you are getting data from these remote tools, and that physician is looking at them, you may also be able to bill 99454. A caveat here, if you're billing 99454, it says each 30 days, you must be getting data at least 16 days of that month. What Medicare wants to avoid is that you're just going to get data for 1 or 2 days. No, this is a device that needs to be transmitting data at least 16 out of the 30 days. And these are not specific to diabetes. So an example here would be a lot of congestive heart failure. You know, a lot of those patients are, you know, have maybe a weight, a scale, or something measuring blood pressure. This is perfect example of them getting data at least 16 days out of the 30. Here's just a kind of another way to summarize the 99453, how that connects to 454 and 457. So again, look at your program. Are you currently using tools that you could possibly bill these services? Also, 2 more codes, they're G codes. And these are for physicians or qualified healthcare provider. This is if you are evaluating a video or an image that was submitted. These are used a lot by dermatology, but it could be used if you were looking at foot ulcers on your patients. The thing with these codes is they are intended to say, does the patient need to come in for services? So if they are sending you an image, or let me walk you through this one, or there is another G code for a virtual check-in. So maybe that physician is following up with the patient post-surgery, or they've had hyper or hypoglycemia, you're doing a virtual check-in. The point of these codes is to say, does the patient need to come into the office within the next 7 days? If they don't, you bill these G codes. If by chance you make a virtual check-in, doesn't pay a lot, but it pays something, $13 to $15. If you say, you know what, you need to come into the office, in that case, you don't bill, you would bill the office visit when they either came into your office or under the public health emergency. Sometimes that's being done via telehealth. Okay, we have a couple more slides here, and then we're going to take some questions. Chronic care management. The codes are listed here, 99457, 99458, and 490. Make a note of them. Chronic care management is different than remote patient monitoring. Chronic care management, you need to have 2 chronic diseases, only 1 physician managing that patient's disease can bill them, all of that. My point today is to be aware of it. It is another non-face-to-face billing opportunity. They can be combined. So the 99091 that we talked about, the 99457 and 458 for remote monitoring, and now chronic care management, they can all be billed together. But very important, my last bullet point here, time spent furnishing these services cannot be double counted, and they cannot be rounded up. So 99091 required 30 minutes. If you're going to bill for the remote monitoring, that's 20 minutes. You need to have had 50 minutes to be able to bill both of them. Document, document, document. Who provided it? What was provided? And how much time? Now they can be added together, but they can't be double counted. There's also some codes for telephone assessment that Medicare has been covering under the public health emergency. We don't know really where that's going to land after the public health emergency, but just be aware. All right, just ending here, we'll take questions, is just the telehealth. I want to make sure you understand that kind of pre-public health emergency. Patients could not be in their home. It required audio and video. Lots of changes under the public health emergency. They will allow audio only if visual and audio are not available. Patients can be in their home. That was huge. There was clarification provided that RNs and pharmacists clearly can provide DSMT via telehealth. They provide a lot of flexibility with CGM coverage. CGM coverage required, a visit every 6 months. There was some flexibility. A patient couldn't come into the office. I want to state these, but just know we need to kind of be alert that once the public health emergency goes away, some of these restrictions may go back. So kind of preparing for post public health emergency. Documentation's important today. It's going to continue to be very important. Figuring out the telehealth is going to be important because some patients actually have really started to like telehealth and they may not want to return to in-person visits. So thinking that through, how's that going to work? ADCES, AMA, others really pushing for Medicare and Congress to continue allowing this expansion of telehealth services. Stay flexible, document success stories, continue communication with your referring provider. All of that is going to continue to be really important, not only now, but under kind of post-public health emergency. All right, so I'm going to kind of end there. Jasmine, I think we have a couple questions, which would be awesome.
Yeah, we do. So the first one that we have here is, and Adriana, we may need some context to this question, but when the patient attended 4 sessions, can the program include the first session when submitting the reimbursement? So are you referring to DSMT or DPP?
Well, I think they're going to be DPP. I'm guessing if it's a 4 session. So in that case, they could, but I would recommend that they should have billed the first session when they provided that. And then at the 4th session, then bill that code. There would be no reason, in my opinion, to hold that claim until you got the 4th, unless there was something that I missed.
Okay, we'll wait for any reply on that. But the next one is, are there sample consent forms?
So I have not seen any. And again, under the public health emergency, Medicare has been really flexible. Like they literally will allow, you can document patient provided verbal consent prior to starting telehealth service. So I haven't seen a specific form. Again, you could certainly ask your MAC, but at a minimum, document who gave you that consent, the date it was provided, and making sure that they know that they will be subject to a copay.
Okay, and then we have a question. So can't we do remote DPP under the providing education part on remote monitoring? I don't know if I could understand.
You say that again? Let me see if I can look at.
Yeah, it's okay if you want, maybe provide a little bit more on that question.
I actually think that she answered that question because I think she was pretty clear that we can't do virtual DPP and get it paid. But I was wondering why not, since on that remote monitoring, education is specifically listed. So I think my question's already been answered.
Yeah, so I think I wouldn't use these remote monitoring codes as your primary DPP billing. To me, then you're leaving revenue on the table, because you could be billing the DPP, whether if it's for commercial, it could be the 0403T. If you are a Medicare DPP provider, you could be billing G codes. But if you are 100% virtual, then there may be opportunities for you just under the remote monitoring, but there may be leaving money on the table there. Kay, did that answer the question?
Yep, she wrote in there,
Okay.
yes, thank you.
Okay. Okay, I think we are, good on time here, Jasmine, but I am happy to stay on for another, another minute or so. If there's any other questions or comments, would love to get feedback.
Yes. So if you guys have questions, drop them in the chat. I know that, when you guys are thinking of your DPPs and DSMS programs and, offering MNT, this is a lot for a lot of you guys if you guys are just starting. So these are things to like really take these slides back and think about how you can, best incorporate all of these services to, within your health system to, get the full reimbursement. And obviously, most important part, reach those that are at, in need of these services. But as you can see, there's many different things that you guys can kind of offer and bill for. It just will really depend on which kind of path you're going and what you guys already have established. If you're already a DPP, your system's thinking about, starting an accredited program, and or if you're in an accredited program and you're thinking about adding on DPP, all these services really do complement each other.
Absolutely.
Mhm. And then,
Jasmine, this is Sheila. I'm sorry. The question I had at the beginning, I'm not sure if I missed the answer to that about
okay,
the enrollment.
okay, let me go back to that. I thought maybe you dropped it in the chat to everybody.
I did, but I can now if you
Nope,
want me to.
I'll go ahead and read it for you. That's no problem at all. Let's see, the question is, my billing department wanted me to ask this question for MDPP enrollment. Does the organization have to do anything with the provider profile and impact?
Let's just see. Let me try to see if I can. Oh, that only went to you, Jasmine. I was just trying. I didn't quite understand it.
Yeah, let me drop it in the. I'll drop it in the chat to everybody.
Okay. Yes, for MDPP enrollment, does the organization have to do anything with the provider profile and impact? So I'm not quite sure if I understand that, but there are 2 steps to become an MDPP. So you need to be a Medicare provider, and then you do need to have a separate application to become an MDPP supplier. And within that application to become an MDPP supplier, there are some unique questions that they ask that are different than if you're billing other Part B services.
So yeah, so I was hoping that our billing person joined the call because she was in another meeting and she sent that to me to ask. Because when we enroll and using the NPI number, you had to also enroll a provider that would be a part of the MDPP program. And so in doing that, she used my NPI number, but her question was because providers, we also have to update in the impact system. And she was asking, did she then also have to go into impact and do anything else with my provider profile?
Now, Sheila, is
Yeah.
impact Illinois specific system?
It may be, and I can find out. It might be.
I think it is. Like, I'm not familiar with the impact.
Okay.
There are unique things with MDPP because, like the YMCAs or MDPP suppliers, and that's not a typical Medicare provider.
Okay.
So there are some additional steps.
Impact. Carly is saying impact is with Medicaid.
Yeah, I believe that impact is because now within the last year, Illinois Medicaid is reimbursing for both DSMES and the DPP. So impact is a way so that you get reimbursement from Illinois Medicaid plans.
Thank you, Carly.
So I have some slides, Sheila, that I can email you to from when they did training in August.
That would be great, Carly. Thank you.
Yep, I was going to say, I think it'd probably be best to refer to IPHI's, and I believe that's you, Carly's technical assistance for Medicaid, since it is so obviously state specific. Thank you. Yeah.
Okay. All right, well, thank you, Jasmine, and thank you to everyone. Really appreciate everyone's engagement and asking the questions. I really, really do appreciate. There were a lot of great questions asked.
Yeah, everyone. And thank you for joining. I'm going to hit the stop recording button now. So if you guys do have any follow-up, just let us know. We'll send these over to